See, in a world where we have so many diseases which are competing for attention, why do we need to focus on mental health illness? For this, I'm not going to give you one reason, but 1 billion reasons. If we look at the number of people, it's not like the elephant in the room, it's like a wild elephant in the room. The point is, can we hear this elephant and do something about this elephant? If we look at it, 15% of global disease burden, 1 trillion US dollar in economy. And it's not a trend which is coming down, it is rising. Now, number of people on psychotropic medications are increasing, and surgery is a significant event that really turns on mental health illness into a different spectrum. US already had its processes when it came to mental health illnesses from personal to the community to family level. But we in India, we were having sporadic pockets of activity. It was 2015 when we actually started looking into there and major surveys were launched. We found the prevalence rates for major mental disorders, and what we calculated was the DALY, which is the disability adjusted life years, and we were really surprised at the percentages it was affecting their life. If we look at the prevalence in India, the burden of mental health illness, it's around 14.4%, in which anxiety and depression lead at 6%. Schizophrenia, bipolar, and other disorders, they follow down. It looks like a small number, but we are looking around 70 to 80 million Indians who are battling with one mental health illness or the others. And if we look at depression, anxiety, and eating disorders, the women tend to have them almost double than men, and as they age, the incidence increases almost till their 70s. But schizophrenia and attention deficit disorders are more prevalent in men, and the age distribution is as depicted, the blue being for men and red being for women. Bipolar disorders is more or less the same in male as well as in females. How many of these patients do get access to treatment? There's a huge lag now. There is social stigma, there is ignorance, there is no insurance, there is lack of infrastructures, personnels, and there are no comprehensive integrated. I mean, how many of us do interact with psychiatry or neurology department frequently? We really don't. And India is world's suicide capital with 2.6 lakh deaths per year. It is accounting for 38% of total suicides in the world per year. And many of these are doctors in this list too. When we look at mental health illness, we could have impact which is mild to moderate when we have, which is generally what we see in majority of the cases, which is generalized anxiety disorder, depression, eating or OCDs or PTSDs. On the other hand, this could result with major impact, a serious illness, as is schizophrenia, bipolar, major depressive disorder, severe obsessive OCDs. These patients would fluctuate from excelling, thriving, unsettled to being in frank crisis. And it's our job to find out the patient, and they could be anywhere in this mental health continues. So, how do we identify at risk patients? For this is what we go. This presentation in these 20 minutes, what I figured out were 7 tenets of method to madness. Shakespeare was very eloquent when he said this for Hamlet, but one of the main things that I realized for us to approach this was to start fixing our vocabulary first. Unless we take away the demeaning context to it and the stigma to it, the progress is not possible. So this is, I'm putting as right there after acknowledging the problem. The second tenet, or M2M as I'm going to call them, is start using the right vocabulary. He's not bipolar. He has been diagnosed with bipolars. So how we speak about the illnesses. So while the drama has to be avoided, at the same time, trivialization. If we check up on Twitter, now X, these diseases are being trivialized so much, which is counterproductive. I do understand just changing the terminology doesn't help without changing the underlying basis, but it's a start which we need to do. Now, how can we encounter a patient with mental health illness? Number one scenario, that it's a diagnosed illness who's on a regular treatment, who's in a remission, and he informs voluntarily. Now, this is something which constitutes a very minuscule fraction, but this is a subgroup where you could plan your anesthesia, understand what are the drugs, what are your implications on there, which need to be started. The ideal situation, which is mostly not encountered. The more common is it's a diagnosed mental health illness, which could be on a regular or an erratic treatment in any spectrum of the disease. No one asked, no one told. And this one is a nightmare because the drug interaction of these drugs, these are the patients would have arrhythmias, would collapse, would have serotonin neuroleptic malignant syndrome, are really stormy cases and higher chances, almost 5 times increase in 30-day mortality. The other scenario is that the patients themselves don't know, they haven't been diagnosed, so they are not on any treatment. So we would not have any drug interactions to worry about, but we can precipitate a full-blown psychosis in this patient or a full-blown depression or any health spectrum, which is going to give a lot of problem in emergence as well as in the post-op period. The other scenario that we could encounter is when the patient is in acute psychosis. He's been brought in for sedation or he has been called in for analgesia. These patients are often victims of violence. So you could have, I've put a lot of thoracic epidurals on patients in fractures where the incident was triggered off by there, or it could be for emergency scenario. There's another scenario where the patient may be having no neurocognitive disorder, but it's the anesthesiologist who has an untackled mental health issue. Now, which is a journey for another day, but that's something we also need to address. The third M2M, which is the most crucial, is taking history. How many of here feel comfortable in our PSC asking the questions that do you have any mental health illness? Even I realized that I wasn't there. I understand it's awkward. How do you ask? But now I realize it isn't that difficult. If you ask them, you are having surgery, you are stressed, you would be scared. Have you felt scared, depressed before this? Were you medicated before this? And if you're feeling awkward about those direct questions, they are excellent questionnaire tools. PHQ-9 carries no stigma. They are easy one, but they can identify the problems. And once we need to know the history of medication, substance abuse. Have been there any history of suicides? Is there any suicidal, homicidal episodes of psychosis? Any major life event in the past? Anything which would suggest psychological vulnerability needs to be encountered, and then we can have a proper. See, in a world where we take diabetes, hypertension, IHT are almost worn like badges of honors for which we ask history and get detailed one too. It's high time we start asking these questions, because if we knew and encountered a scenario and patient safety was compromised, it's not something that you want to deal with. Now, looking at the major depression, there are a lot of subtypes of depression, but what we need to know is the depression is an independent risk factor for morbidity as well as mortality, and whether it comes as a singular entity or it is a part of bipolar disorders. In a bipolar disorders, you get both the spectrums of hypomania as well as mania. A patient will have subthreshold depression, which will ultimately, and most of the time, a patient would be in mixed scale. And the scales that we can use for these are Hamilton depression, Montgomery. These are very easy scales. I've started using them. And the same way for hypomania and the Young mania risk scores. According to the cycles, you will have the subtypes, but it's important to know the definitions can be provided by the psychiatry departments. But you need to understand that baseline patient is in a maniac spectrum or is in the depression spectrum. And as the history is evaluated, you will see that the patient from at risk stage to prodrome stage to the first episode of full-blown mania to the multiple episodes which fluctuate will come into chronic stage. The functional physiology is going to decrease with time, allostatic load is going to increase with time, and the medications and interventions that the patient is going to be on is multiple. So it's indirectly going to indicate greater scale of problems for you in the post-op period. For schizophrenia, we have positive and negative system. Now, there is nothing positive about the positive symptom. It's something the disease is adding on, like hallucinations, delusion, disorganized speech. And negative symptom is something that the disease is taking away from the patient. So, aflattening, alogia, anhedonia, evolution, or impaired grooming, physical appearance, all those factors come into the negative. And 70% will have additional cognitive defects which will be there. Depending upon the duration. That's why the duration of symptom is important to ask in history. It can be a brief psychotic disorder if it's less than 1 month. If this was 1 to 6, it's a schizophreniform disorder. More than 6 months, we are looking at a full-fledged schizophrenia. And if you look at this graph, The red line indicates the positive symptoms, the hallucination, delusions. And this starts very early on. There are a lot of genetic, epidural, we don't know exact, but there's a lot of work which is happening. Adolescence is the age group when these symptoms starts manifesting. But that's the time because they're easy to miss because of the teenage years. But then once you have the acute episode, it's impossible to miss it, that acute psychotic dopaminergic influx. Antipsychotics control these positive system and they will bring down. The negative symptoms are not under the purview. They will have an uphill, and on a chronic treatment, this is the spectrum the patient would be in there. So depending upon the age, depending upon the onset, the patients would come in there, and positive and negative system is an easy way of correlating your severity for schizophrenia. Now, what is causing all these problems? Dopamine, serotonin, norepinephrine imbalance. There is genetic predisposition. There is a lot of work, as I said, which is happening. These drugs help us, but they do not work in all the cases. 30 to 40% would still be refractory. So there are other mechanisms which we don't know. The surgery anesthesia itself, they are the pro-inflammatory cytokines which come in there. They break the blood-brain barriers, and these astrocytes are more permeable. So we think there is some damage which is happening because it's rather than the neural functional structure, it is the synapses which are how they communicate with each other, manifest the symptoms of these diseases. Whatever the baseline physiology, how does it concern us when it comes to anesthesia? If we look at the cardiovascular system, from simple orthostatic hypotension to arrhythmias to ischemia to prolonged QTC to prolonged PR, QRS intervals to silent MI, they affect massively. It's 5 times in schizophrenia and 3 times in depression. So when they are coming in for anesthesia, simple are ephedrine and normal vasopressors may not act. For them, phenylephrine would be a better choice if you want to deal with. Sometimes we encounter refractory hypotension and we can't figure out what's happening. It's a good idea to go back to the history and find out if these patients are on any other co-medications which we missed out initially. These patients, as a coping mechanism or as such because of the disease itself, have a higher chances of substance abuse, almost 30 to 45%. Tobacco, alcohol being the most common, but the other ones are fairly common in this group. And because of these additional plus the disease itself, they have the chances of having COPD, pulmonary vascular diseases, stroke is higher in patients which have coexisting mental health illness. A major Pandora's box is the psychotropic medications that these patients, huge side effects from neuroleptic malignant syndrome, serotonin discontinuation, multisystemic infection, and the cytochrome P system induced toxicity. Most of them are metabolized through cytochrome P. 2AD6 is a major one which encounters changing the metabolic profile of so many other drugs that we use in anesthesia. They have a depressed immune system, so chances of infection, delayed wound healing, going into sepsis is much higher in patients who have a coexistent mental. The thermoregulation is grossly disorganized. They tend to have higher temperatures, but the fall during anesthesia is more propounded when we go into there and will have bigger effects. Sudden deaths are more common in there. So, and the bleeding disorders, almost 36 to 40% higher chance of bleeding, blood loss products being more in mental health illness. So this is a huge impact. And also looking at the patients, if we look at a normal patient which undergoes surgery, what are the incident rates for perioperative neurological dysfunction? So we are looking at a postoperative delirium in about 30% of the patient, which could be hypo, hyper, or mixed. Hyper, which we commonly recognize, is only 20%. It's hypo in most of them. There can be delayed neurological delivery. If there is some dysfunctioning in 30 days, it could be postoperative cognitive decline, which is the changes which is up till a month, which is about 10% of the patient have, and 1% of the patient will have the PND. But when this entity is with mental health illness, these entire ratios are propounded, extrata, and mortality morbidity risk. As I've been saying, 5 times increased mortality risk for schizophrenia, 3 times for depression, almost 1.67 for anxiety. So it's a huge, we're talking about numbers of people which will have these blowouts. Like, I would like to ask question, which one of these following drugs does not have discontinuation syndrome? Would anyone want to take that? It's okay. The answer to this question is lithium. And more important than the answer to this question is to know what is discontinuation syndrome. Now, most of the antidepressants, if any of one of them are taken off, most of them, they will manifest into a very strong withdrawal symptom, which could, depending upon which drug the patient was, it could be discontinuation of mouse, it could be serotonergic withdrawal, it could be anticholinergic withdrawal. And these symptoms are worse than what interactions we could have done. And these symptoms last for weeks. These are not for small. So the general underlying principle is to continue with most of the antipsychotic medications except few, lithium being one which definitely needs to be discontinued for 72 hours, ideally before surgeries, because the hypersensitivity of these dopamine receptors. So if we look quickly at the drugs, the major drug groups that we have is the selective serotonin reuptake inhibitors. These are the most common groups of drugs that we give there. Now, with these group of drugs, you need to continue, but you have to remember that tramadol, morphine, within and all these dextromethorphan drugs should be avoided when a patient is on SSRI. Similar for SNRI because you can precipitate the serotonin syndrome. I will come to that in a minute. The mouse, they used to be irreversible and it used to take 2 weeks to recharge that receptor. So it was 2 weeks, but now we have one or two, the reversible ones, MAO-A. Except for that moclobemide, rest all should have a washout period. TCAs we hold for tricyclic antidepressants 2 days because they have and avoid sympathomimetic ketamine, ephedrine when we have got TCAs along. Atypical ketamine, these need to be continued in the pre-op. Lithium, we stop 72 hours. One, it has other drugs that we commonly use in our anesthesia like ketorolac, NSAIDs. They increase the lithium level, so they manifest the toxicity much earlier because of the drugs that we are giving into them. So renal toxicity becomes profound. And secondly, it has a very narrow therapeutic windows and on which gets totally altered with multiple drugs, which you can't control unless your serum continuously monitoring and titrating it, and neuromuscular agents. So lithium, we need to stop 72 hours. Valproate, we need to continue, but we need to remember that this comes with huge bleeding risks. So those need to be monitored. Carbamazepine comes with lot of other drug interactions. It is still used a lot in India because of its cheap price and still being an effective drug, so it has side effects. So those need to be minded. Patients could be taking on opioid abuse. So what do you do with them? You continue with what they are doing, prescription drugs, but avoid fentanyl in those patients. And the symptoms, if they are getting worse, clonidine is a good drug of choice to use with them. Patient could be on cocaine. It is almost 5 to 6 times higher chances of them being on inhalants or marijuana or cocaine. So these drugs, obviously you need to stop them, but you need to be mindful. With cocaine, acute intoxication, anesthesia requirements are more. In chronic, they go less. So accordingly you do, and you expect lot of hemodynamic instability in these patients. With inhalants, toluene is the most common one which is in being abused. There's a lot of bronchial irritation and pulmonary edema, but this is a subgroup in which you need, the evidence base says that you need to give GA rather than regional for these patients. These patients may be on drugs to take them off the substance abuse. So you continue doing those drugs, but don't use buprenorphine with methadone and vice versa. Naltrexone and other groups need a longer time because they may be the oral one, which is 72. If they are depots or the long injectable, almost 4 weeks before surgery because your analgesics would not work, or you would have to think of different analgesia modality if the patients are on those. Newer medications, we have lesser data, but the general line is to continue with this, whether it's Dexa, sublingual films, olanzapine, or lumateperone. What about benzodiazepines? If the patient is taking them, continue taking them, but do not start new benzodiazepines in a patient of mental health illness. Same with antipsychotics. Enflurane is a bad combination with antipsychotics, which you need to there, and the patients may be on stimulants. So you need to be mindful of the entire drugs that the patient could be taking. Now coming to what is neuroleptic malignant syndrome that I've been speaking about. This is induced by the antipsychotics. We believe the mechanism is at a dopamine flux, which is causing Parkinson-like rigidity, and also at the thermal regulation. So there is the symptoms which are very similar to malignant hyperthermia, when it is full blown, or it may be mild. But there is typical history. This starts 1 to 3 days after starting antipsychotic, or it may be few weeks. So there is a longer time. It's not immediate like serotonin, which is more quicker within few hours or a day, where it manifests with the drugs. So the timing is there, because introp, when you have a patient which looks very much like malignant hyperthermia, it could be serotonin syndrome, anti-neuroleptic malignant syndrome, or malignant. So how do you differentiate? Going back to the history, which drug the patient has been taking. For serotonin uptake, what's happening is we have a medication which is increasing the level of serotonin by inhibiting the reuptake of the drug. So whenever we give additional drugs in anesthesia, fentanyls, tramadols, other ones which have similar mechanisms of action, the serotonin flux goes so high, and there is massive norepinephrine release which produces these symptoms. So we need to stop the drug, obviously. For serotonin, we have the Hunter toxicity criteria for diagnosis. This I am putting in context to malignant hyperpyrexia, which we know is with our anesthetic drugs. We know its mechanism is through the calcium, but when they are presenting hyperthermia, hyperprexia, tachycardia, these patients look very similar to each other. And it's important to know the difference, because for serotonin uptake, we have cyproheptadine. It's an antagonist that we can give, which will come down. Though the basic supportive symptoms stay the same, bromocriptine, amantadine, benzodiazepine is the treatment of choice for neuroleptic malignant compared to dantrolene, which is for neuroleptic malignant syndrome. These were the major ones, which incidence are about obviously 2 to 3%. But the incidence of anticholinergic, orthostatic hypertension, arrhythmias, and sedations are far more common, and almost 60 to 70% people would be seen. Incidence varying with different group of drugs. First generation, all of them have a significant. Second generation, slightly less, but aripiprazole, brexpiprazole, and risperidone. There are three drugs which don't have any QT super long. So if you have a comorbid cardiac conditions, somebody had put these drugs are the one which you have a choice as an alternative. And it's during anesthesia. For ECT, we don't really need to do much about our anesthesia drugs, but remember that they do have effects on seizure thresholds. So that's one thing you need to do, and that's what we are trying to induce in the ECT. More importantly, it is important to know what to do with the psychiatric drugs that the patient is on when we are planning anesthesia for ECT. For example, a lithium. We want discontinuation syndrome, but here we just decrease the dose, and ECT is almost a medical emergency for managing uncontrolled mania or a severe depressive patient who can be a risk for himself. So in those cases, you could go ahead, but you do recommend decreasing the doses. With valproate, use etomidate as an induction agent, because what valproate is doing, etomidate is counterbalancing, so it becomes a great combination during ECT. Carbamazepine, for that, you reduce the dose, hold the dose night before, though I know we have said we continue with them, but during ECT, there are slighter different modifications that you need to tweak out for there, and a different group of muscle relaxants which are advised with different group of drugs. There are many drugs for which they do have effect on thresholds, but we don't need to make any changes. But we do need to consider that if it's a benzodiazepine, for an ECT, definitely stop it out there. Though we have a recommendation to continue so that there is not sudden, but exception is for ECT. There are not many drugs here, and I know everyone can't remember everything, but it is important to consider when you have that drug, what are the points that I need to take into account? And what are the drugs that we are looking at, from SNRIs, dopamine to GAD, and the atypical? The usage of quintapain, risperidone, aripiprazole is very common now. So these are the drugs that we need to be more aware of and understand better. All of them have a huge profile, but each one has specific. For example, clozapine causes agranulocytosis, so white cell count is more important into there. Valproate has got more of the liver toxicity. Some has got metabolic effect, which is there. So whichever drug that you have, look into it and see what are the specific points that you need to see. The common mood stabilizer and antipsychotics niche serum monitoring is there. Liver function is a mandatory test for most of the patients on mental. With lithium, thyroid and renal are the more prominent one, which is there, and hydration is more important. For chlorpromazine, the extrapyramidal symptoms should take into account. Is there any other, right? Same with the respiridones. So WBC count, renal function, liver function are the basic mandatory functions whenever you have mental, even if it is small. So now going forward, we know there is a lot of drugs we have identified. Now comes the risk management strategies. There has to be a specific orientation of these patients before they go in for patients. You have to stratify that risk. A person who's got everything normal, otherwise physiology, 40-year-old, but is going through a major depression, you would have to take a call. Elective high level surgeries, level 13, 14, you need to actually postpone that and treat the depression and not ignore it. Otherwise, your mortality, morbidity, and success rate for the surgeon. So hold that surgery. Meanwhile, you do cognitive restructuring. It is just how they change their act. Get in consultation with your psychiatrist. They can help, the psychologists. They can help. And patients' primary caregivers are the most important helplines which will help you in truth what is there. So when it comes to which anesthesia would you choose one over there, it is totally individualized. We have had cataract surgeries in schizophrenics which are done under GA extremely safely as long as you know what you're doing. Or on the other hand, regional can be a very good choice with a sedative combination of a drug. But more important than the technique, it's important to know your ECG mandatory, monitoring is mandatory, your temperature regulation core is absolutely essential, your water fluid intake and electrolytes, because the toxicity of various drugs is affected by our hypotensions and all there, and renal is one of the most common problems encountered in the post-ops. What about when we are giving GA? The titrations need to be slow. Can use most of the agents can be used up, but the MAC requirements are much lesser. So titrate it to a lower level. The toxicities and other things would be lesser. Neuromuscular monitoring and BIS monitoring is an ideal techniques to have when you are giving general anesthesia to patients who have mental health, just to titrate your things. What about analgesia requirements in the post-op period? The depressive patients and would have higher analgesia requirements. They have the same pathway. So in these patients, rather than hiking up your analgesia doses, you might need to hike up the antidepressant doses rather than going. Some patients are giving everything and they don't have adequate pain relief. Review whether you need to increase that dose. Schizophrenic, on the other hand, a different problem because they are insensitive to pain. So their thresholds are very low. They would not complain. But on the other hand, they miss out on silent ischemias and frank ischemias. So third, fourth day of a patient has a sudden collapse, it's a very likely possibility that this patient could have been on a drug or could have been on there. And for these patients in post-op period, you need to have troponin T monitoring because they would not have pain. And since they're not bothering us, we ignore them and then they have sudden collapse. And other important is you need to know the drugs, if you have stopped, when to recontinue them, and what would be their disease modifications. And the post-op complications are a definite entity, especially in the first week. So the first 48 hours, they need to be in a monitored HDU environment, even if they look prima facie. Post-operative paralytic ileus, sudden deaths, infections, all other problems are a lot common. There's another subset of patient, as we're saying, when the patient comes in acute psychosis. Now, irrespective of what kind of a psychosis is there, and before we jump onto the diagnosis, always be mindful there are many conditions which mimic, from your traumatic brain injuries to iatrogenic drug induced to tumors. Even HIV patients in their neurological manifestation can come with acute psychotic episodes, to epilepsy which has not been diagnosed, especially the temporal lobes, to thyroid. So whenever you're looking a patient which present to you first time on in acute psychosis, people don't know what it is. While you're trying to control the psychosis episode, be mindful of the differential diagnosis. And it's important to know that the hallucination and the delusion that patient is very real for them. So do not pretend to agree, reason, dismiss, minimize, argue, or elect. You need to accept them at their face value. And another thing which was very disturbing was Dr. Vandana Das' episode. A 23-year-old medical intern in a hospital stabbed brutally by a 43-year-old school teacher who's struggling with substance abuse and mental. It just shows that we haven't really thought about this. We are exposing ourselves to psychotic, though most of them will not harm, but there's a small subgroup which is very, and it's important to identify and have your safety first. The language, conjugality, and there are tools. I've gone through a full one-day workshop learning how to manage what we call an ABD, an acutely behavioral disturbed patient. There are domains of de-escalation for where they actually treat you. You have to have your exits, you have to have arm length. What are the body language you will not do with a mental health patient, which can trigger your language, which needs to be short, small sentences. You use fogging, you set limits, but you also give them kind concession, which can help you manage these patients tremendously. And but in some cases, de-escalation is not going to work. You have to think of rapid tranquilization. And I know most of the patients in ICU, whether they're having a delirium or a psychotic episode, generally we go to haloperidol or Serenase. But we have wonderful drugs which have lesser, because haloperidol, if given in a Parkinsonism patients having huge crisis situation, which can land up with there. And since many of them are not, so if you have an undiagnosed QTC or an undiagnosed Parkinsonism, droperidol, midazolam, ketamine are very good options. And the other options that we have in the algorithm, once the first line, these are the evidence basis of their treatment for the other techniques before you come to their lorazepam, buccal, oral olanzapine is one wonderful drug, and oral aripiprazole that we can consider giving in these patients, which will really calm them down with not so much side effects. Otherwise, it would be intramuscular, but intravenous, you have to remember, with resuscitation. Once you sedate acutely psychotic in a frenzy patient, there is a very likely chance for him to collapse suddenly. Some of them will not even respond to them, and you may even have to go for emergency ECT. Other method, there are lot many new stuff which is happening in mental health illness. There is brexanolone. It's a GABA A receptor antagonist for postpartum depression, especially when it is with post-dural puncture headache. It's a deadly combination. So this is showing great results in those patients. Esketamine is showing wonderful proof of concept studies for depression. So a patient who's having depressive tendencies, and we can see there, maybe using ketamine intraoperatively, there's a huge opportunity of actually helping him out in the postoperative. Voice biomarkers, huge potential. By just voice of the patients, they can identify by 95 to 96, another exciting prospect. There are a lot of digital mental health tools which are available for us. I won't go into details, but they can actually manage your stents, and they can have what you call an intervention given to them, which will help us control their symptoms. There's a lot more to be said, but I want everyone to look at John Nash in the middle. He was diagnosed with paranoid schizophrenia in his 20s, but with a very supportive mathematics society, he managed to get a Nobel Prize in 1994. From agony to ecstasy, mental health illness can be very cruel for the patient. And as anesthesiologists, not just for the sake of safe anesthesia, we really need to advocate for people who are suffering in silence. Every drop of change will help in changing the stigmas which is associated with these illness. And what mental health illness really requires, rather than sunshine and drugs, is more candor and more unashamed conversations. And if not now, when? I would just, one takeaway if I have to give to everyone with these 20 minutes is, please start asking questions about mental health illness in your history. Start reviewing your drugs properly, and just treat it like any other disease, any other patient who needs help that we can provide. Thank you so much.